And for part 2 of week 2 is mental status and substance use. As we learned in the prior recording, our body systems are a holistic mesh of spiritual, cultural, mental, physical, and they all impact one another. And so when you see patients with unexplained symptoms, there's a great deal of patients with depression that present with somatic complaints, right? These are complaints such as body aches, sleeplessness, restlessness, GI upset, nausea, vomiting. Our minds are enmeshed with our body. They're part of our body. And so our mental well-being is very impactful on our physical well-being. They are interrelated. And it is not uncommon to see GI complaints, weight loss, endocrine issues, increased problems with infection and cancer, depression, eating disorders, because it's all related that way, that more stress you put on the body, the impact that resonates out affects all the systems. You can also see anxiety disorders, generalized anxiety disorder, social phobia, panic disorder, PTSD. We're seeing it more and more because we're in this global pandemic and our resources are stretched thin. We don't have our normal support groups, and then we have stresses and losses as well. In the past 4 weeks, this one is one of the easy screening questions. The past 4 weeks, have you had an anxiety attack, suddenly feeling fear or panic? And so when you're looking to considering panic disorder, right, a lot of times mental health wise, we're very direct and we ask them specifically, asking them about their drug and alcohol consumption, very specifically. CAGE is a screening tool that we use to assess manageability of alcohol substance use consumption. We're seeing a little bit increased use in this global pandemic, so this is very appropriate for our current times. Now remember, click through these slides so that you can do the Kahoot and get a baseline feel for how you're doing with the content itself. And it's a little competitive and fun and less boring than hearing my voice the entire time. Now make sure when you're looking at this mental health chapter that you understand the terminology, differences between level of consciousness versus orientation, right? Are they alert? Are they aware? Orientation wise is like the questions that you typically ask, ANO times 4. So you're oriented times 4. That's the personal identity, place, time, and situation. Be careful nursing wise if you ask questions outside of those traditional 4, because when you're giving me handoff and your patient doesn't know the president, does that mean that they are not ANO times 4? My assumption would be that it is one of the 4 questions: who they are, where they are, what's the date, and what's the situation, right? So typically when you give handoff, you're going to say what they are not oriented to, right? So, my patient's oriented, ANO times 2. They are not oriented to date or situation. They know their name and they know they're in the hospital, and that's it. So there are differentiations between level of consciousness and orientation. We also have attention, like the ability to focus or concentrate. And you've seen people with who are easily distracted with a short attention span, right? And it is not uncommon, especially in high stress or with other mental conditions, to have poor attention, poor memory, and maybe even altered perception, right? This sensory awareness of environment. You'll also want to assess the patient's thought process. Is it logical, coherent, that makes sense? Is it relevant to their thought process, right? And then the thought content. What are they thinking about? Are they obsessing about something? Is it appropriate for the situation around them, right? Is it congruent with what's going on? And then insight is their awareness into their own behavior, right? So if they are able to see and recognize that their behavior is normal or abnormal, an example would be like a schizophrenic patient who is seeing bugs on the wall and they understand that like the picking and the pacing that they're doing, they do not understand that it is abnormal because their insight, their own personal insight, is altered because of that process. And then the judgment is comparing or evaluating alternatives. So more risk-taking judgment, right? Or judgment that is dangerous, right? Where you're going to run onto a freeway. All of those things are melded through mental health in general. And then affect we touched on briefly before, looking at what is observable. And a lot of times you want to see, is that affect matching the rest of them, right? Are they saying, one thing and then their face is very flat. It's not moving much. It looks kind of like a statue almost. Typically you'll see with that flat affect, which is what it's called, that the tone of their voice is also very flat, and that their demeanor in general is maybe more reserved and more subdued. And then mood in general, right? So a depressed mood, a euphoric mood, right? A sad mood. You can ask patients about this. This is also, you have observed characteristics that may be occurring at the same time. If they appear anxious, you'll often see wringing of hands or pacing or a fast pressured speech pace, right? And so kind of getting an understanding of that underlying mood, it has an impact on how worried you are about the safety of your patient overall. Language is their capacity to comprehend and to express themselves through their native language, obviously. And then higher cognitive functions. This, you'll see some of the higher cognitive function tests where they can use abstract thinking, they can construct objects, right? And you'll see this more with dementia and delirium patients. So just on physical examination, we already touched on this, but appearance and behavior. And this is you kind of getting a better idea of what do they look like? How are they dressed? How are they behaving? How is their speech and their movement? Are you seeing physical tics, right? Do you see, like if with tardive dyskinesia, you see the tongue rolling and kind of lip smacking, and there's a lot of nonstop movement of the face. That is fairly easy actually to see. Behavior-wise, do they pose a threat? That's that initial piece, is like, do they appear to be a threat to self or others, right? Are you seeing them with violent behavior where they're lashing out? Are they pacing? Are they agitated? What are they saying? And how are they saying it, right? Are they screaming? Are they very subdued and flat and calm? And there are a lot of kind of circumstances around, but you do your best to take in the information and then assess the patient's needs and kind of the threat level of, are they in imminent danger currently? And make sure you chart it very, very thoroughly, right? Some of the examples of speech and language, I tend to speak very quickly, but that's the cadence, like the tempo of my voice, right? It's very fast, or pressured speech. You'll see a lot of different alterations in speech, not just slurred speech, which could indicate that they're altered either with chemical substance, or they could actually have physical function that is limited, like a stroke, right, which will give you slurred speech. But you'll also have things like echolalia and word salad, where you'll hear repetitive sounds, or it won't even make sense at all. And so make sure you know the definitions really well on this in case it shows up on a test, wink, wink. And then thoughts and perceptions, right? And we ask directly, do you have any thoughts of harm? Of yourself, of others, right? Have you thought about killing yourself? And if that's a yes, it is deeper into what that means. Do you have a plan? Tell me about that plan, right? Do you have the means? So if the plan is, I'm going to overdose on a particular drug, do they have that drug? Do they have that access there? Because each layer puts it more and more risk to self or others. And then cognition, right? Your memory, attention, vocabulary, abstract thinking. When you think mental health, it's not just like a psych disorder, right? There's also progressive problems, dementia and delirium, right? So testing for aphasia, looking at, it's pretty straightforward, but word comprehension, right? Have them follow your commands. You ask them to do something and watch them do it. Repetition, have them repeat, simple one-syllable words. And you'll see this a lot with NIH, and it's looking at the physical capacity to say the words and to comprehend what's happening and translate that into sound. So these are very, very straightforward. Now, on higher cognitive function, this is looking at constructional ability. So if you're looking at the capacity to put shapes together and then recreate them, or you say, draw a clock with the numbers and the hands themselves. And depending on their capacity for abstract thought, right, you'll be able to see, sort of deteriorating abstract thought. And you also have to have intact motor ability and good vision, right? Because especially when you're looking at dementia patients, where their cognitive ability is more impaired, if they don't have good vision or physical capacity to draw, they're not going to do very well on these constructional ability tests either. All right, my question for you. You've got a patient who's drowsy but opens their eyes and looks at you, responds to questions, and then falls asleep. Is this comatose, obtunded, stuporous, or lethargic? And the answer would be, it is a lethargic patient, right? They're drowsy, they open their eyes and respond to questions, and then they fall back asleep. An obtunded person, right, will open their eyes, but they are slower and they are confused, right? It's a little bit deeper in that alertness. And then stuporous, unaware of surroundings and maybe unresponsive to painful stimuli. And then comatose is exactly what you'd think. It's comatose. So understand what these words mean, just in case there's any test questions. And because this is also how you would chart your patient's level of consciousness. All right, my next slide, I'm looking at the mini-mental exam, and this one is differentiating between, and it's pretty quick and straightforward, right? So it's a score system here, and then you write it in, between delirium versus dementia. And this is a very real problem, especially in the ICU, where you have risks for delirium, which is that short-term acute cognitive dysfunction. And you'll see it a lot with some of the meds that we give you when we intubate you and to keep you sedated, and the lack of windows and all the stressors that are occurring. But it puts the patients at more risk. And then, dementia, which is a lot more long-term chronic issue. All right. And finally, we're going to wrap it up with important screening and health promotion topics. So we'll always end with health promotion screening, but depression and suicide risks, we should be screening everyone. Actually, we end up screening everyone for depression, suicide, and alcohol substance use. But, each facility will have kind of a different set of screening tools typically, but it'll be something along the lines in like the last 30 days. Have you felt depressed? Have you thought of going to sleep and not waking up, right? Have you thought of harming yourself or harming others? Screening for suicide, right? And in this pandemic now, we definitely have this issue, as well as increased drug and alcohol use. And then we've got our traditional screening for dementia as the adults get older. So just kind of a brief walkthrough through this chapter. Make sure you know your terminology and you understand what those differences are.